In the name of Allah, who is most merciful and most beneficent. Assalamu alaikum everyone. I'm Dr. Ambreen and I'm a physical therapist by profession. I welcome you all on online digital teaching system of University of South Asia. This digital revolution will bring a positive influence on both the students and teachers as well. I am going to deliver a lecture on the drugs used in bronchial asthma. This topic comes under the course Pharmacology and Therapeutics too. The point is, what is asthma and which actually we are going to use these drugs. Asthma is an inflammatory illness that includes the dyspnea that is actually characterized by dyspnea and wheezes, and these dyspnea and wheezes are just due to the increased resistance to the flow of the airway through secretion. Dyspnea is actually shortness of breath, and wheezes are whistling sounds in the chest. So they are actually being produced just because there is increased resistance to the flow of the air in the airways, and even they are just due to the presence of the secretions of mucosal congestion. You can see in this picture, this one is the normal airway. You can see this is a normal lumen of the airway. This one is an airway of the person who is asthmatic. You can see in this picture, the muscles are in bronchoconstriction, and further there is presence of some mucus inside it, due to which the lumen has reduced like this. Here you can see. Fine. So this bronchospasm, the mucosal congestion, and edema is actually going to increase the airway resistance. So there would be shortness and wheezes in the chest. What are the triggering factors? What are the factors that can trigger the acute attack of asthma? There are various stimuli that are going to cause hyperresponsiveness of the skin, of the smooth muscles of the tissues, like dust, cold air, infection, allergen, even so many drugs are going to give a stimuli, are going to trigger the acute attack of asthma. What happens in asthma? In asthma, there is antigen antibody interaction. Antigen antibody interaction is on the surface of the mast cells, and the mast cells are going to degranulate. And we know there are so many inflammatory mediators inside the mast cells. When the mast cell is going to degranulate, it is going to liberate so many inflammatory mediators, as there are a number of inflammatory mediators that are actually synthesized and are present inside the mast cells that are responsible for causing bronchospasm, mucosal congestion, and edema. Mainly, inflammation is the primary pathology in whole scenario. In whole case, antigen-antibody interaction is going to lead towards cause inflammation. So what we have to deal is we have to ultimately deal with this inflammation. You can see in this picture at point one, this is allergen. It is going to act on beta cells. They both going to interact, and the beta cell is going to undergo some changes that it is going to release or Ig antibodies, and these Ig antibodies are going to attach to the mast cells, and you can see here it has attached to the mast cells. They're going to destabilize it, and when it destabilizes, it degranulate so many inflammatory mediators like histamine, leukotrienes, platelet aggregating factors, interleukin. So they are going to lead towards causing inflammation. Now I will discuss the drugs used in the bronchial asthma. The possible drugs that are being used for the bronchial asthma will say they are beta sympathomimetics, they are methylxanthines, they are anticholinergics. Basically, the one we preferably use in this classification are beta agonists or beta sympathomimetics. What these beta agonists are going to do is they are actually beta 2 receptors on the lungs, on the smooth muscles of the lungs. What is going to happen is all these beta agonists are going to attach to the receptors, and they are going to cause broncho relaxation or bronchodilation. So they are going to help in the patient of asthma who already have bronchoconstriction, and they are going to cause broncho relaxation. Salbutamol, terbutaline, salmeterol, formoterol, ephedrine, albuterol, adrenaline, they are all beta 2 agonists. Next class is methylxanthine. Methylxanthines are theophylline, aminophylline. Anticholinergics. Anticholinergics, we are well familiar with this. Anticholinergics mean the drugs that are going to antagonize the actions of cholinergics. And cholinergics come under the parasympathetic system, and acetylcholine is the major neurotransmitter in the parasympathetic system. So here, anticholinergics are going to antagonize the action of acetylcholine. Ipratropine bromide and tiotropium bromide are going to act on the muscarinic receptor present in the lungs, and they are going to cause broncho relaxation. They are actually avoiding or preventing or bypassing the bronchoconstriction. Leukotriene antagonists, montelukast, dafilukast, mast cell stabilizers, sodium chromoglycate, ketotifen, corticosteroids, hydrocortisone, prednisolone, and others. Inhalation are beclomethasone, budesonide, and different others. And the last is anti-Ig antibodies, omalizumab. Mast cell stabilizers are those that are going to stabilize the mast cells. Leukotriene antagonists are those that are actually inhibiting the action of leukotriene and antagonizes the action of leukotriene. And leukotriene is an inflammatory mutator. Now I will discuss about the three main bronchodilators, that is beta-2 agonists, methylxanthines, and anticholinergics. Beta-2 agonists are the drugs that are going to act on the beta-2 receptors present on the bronchioles, and when they are going to activate it, it go a chain of reactions, and ultimately it's going to cause broncho relaxation. Fine. Methylxanthines are also going to cause broncho relaxation. They are acting on an enzyme and inhibiting it that is named as phosphodiesterase. What phosphodiesterase do is obviously it will cause bronchoconstriction. So you want to like inhibit that bronchoconstriction, we are going to inhibit this enzyme. The next third one is anticholinergics. It reduces the vagus tone by preventing the cholinergic action on the muscarinic receptor. So in this way, it reduces the vagus tone. So, in detail, the action of beta-2 agonists. Beta-2 agonists, as earlier said, they are beta-2 receptors on the lungs, and beta-2 drugs are going to attach these receptors, and when they attaches and stimulate these beta receptors, and these beta receptors activates an enzyme named as adenyl cyclase. These beta-2 agonists attach to the beta receptor and they stimulate the enzyme adenyl cyclase. Adenyl cyclase increases the production of cyclic AMP in the mast cells, and cyclic AMP acts as an intracellular second messenger, which then increases the activity of certain other enzymes like protein kinases. And the protein kinases, like when increase the activity, they ultimately inhibits the smooth muscle contraction and promotes a smooth muscle relaxation that is actually a required effect. This is a picture to clear this whole story. This is actually a dull picture, but I just want to clear the point. This is actually your beta-2 receptor, and the blue one is your beta-2 agonist. When they both attaches to each other and stimulate it, this beta receptor, it activates an enzyme adenyl cyclase. The adenyl cyclase is actually going to convert the ATP into cyclic AMP, adenosine monophase. And the increased concentration of cyclic AMP converts the inactivated protein kinase into activated protein kinase. And the activated protein kinase leads towards a protein phosphorylation in the smooth muscle and induces relaxation and causes bronchodilation. Now we are going to discuss these drugs individually and certain characteristics about these drugs, like sympathomimetics. We preferably use here are selective beta-2 agonists. The primary bronchodilators used in the treatment of asthma, acute asthmatic attacks. Actually, they are fast acting, they are convenient, they are relatively safe. So they are even available in metered-dose inhalers, nebulizers, and other tablet form for oral use. So you preferably use beta-2 agonists in certain like acute asthmatic attacks. This is a picture of a spacer inhaler. Spacer is used for children to actually cause a proper drug delivery. So we avoid using inhaler. We use spacers along with inhalers. We have divided these beta-2 agonists on the basis of duration of action into two main categories: long duration and short-acting, like beta-2 agonists. Long-acting beta-2 agonist is salmeterol and formoterol, and short-acting is salbutamol, terbutaline, albuterol, levobuterol, metoprolol, and pirfenidone. Salbutamol and terbutaline, the one that is short acting, what they are going to cause is they are selective beta-2 agonists, fine, we know. The inhaled salbutamol produces bronchodilation within 10 minutes. When we are taking through inhaled route, it is going to act in 10 minutes, and the action lasts for 6 hours. It is used for acute asthmatic attacks, but this one is not like suitable for prophylaxis. Side effects are palpitation, restlessness, nervousness, irritation, throat irritation, ankle edema. Palpitation is something you are feeling that your heart is racing. You even feel that sometimes you feel that heartbeat is missing. So the discomfort related to heart is here known as palpitation. Metabolism is in the gut. Oral bioavailability is 50%. Duration of action is oral salbutamol act in 4 to 6 hours. While the salmeterol, that is the first long-acting selective beta-2 agonist with a slow onset of action. Its effects remains for 12 hours, so even twice daily for maintenance therapy we can use. Even for nocturnal asthma we can use. Nocturnal means nighttime attack of asthma. But this one is not like effective for acute asthma just because it has a long duration and slow onset. So preferably we doesn't use in an attack where we want actually rapid and like early effects. Albuterol is very effective in acute attack. It has a very rapid and action duration onset of action. Attacks in the beta 2 route of administration can be oral inhalation. Once onset of action is in 5 to 15 minutes if given inhalation with peak to time to 1 to 1.5 hours. Onset of action is 15 to 30 minutes if even taken through oral route, and peak effect remains for 2 to 3 hours. Neuroagents are also present like phenometrol, formoterol. There are certain non-selective beta receptor stimulants, mean adrenaline, isoprenaline, ephedrine. They are non-selective, means they not only affect on our required beta 2 receptors, they also affect on beta 1, alpha 2, alpha 1, and beta 3. All these other factors. So they produce so many like systemic effects, and due to so many side effects, we preferably not use. Even they are going to produce a very good bronchodilation. So because of the presence of the low efficacy, more side effects, and availability of better drugs, these drugs and ephedrine especially is not being preferred. Now we are going to start the next class that is being used in bronchial asthma, that is methylxanthines. Methylxanthines are the drugs that are going to inhibit an enzyme named as phosphodiesterase. First of all, you have to remember this thing. Methylxanthine are going to inhibit an enzyme named as phosphodiesterase. Now the point is, what is this phosphodiesterase enzyme? Phosphodiesterase is an enzyme that converts the cyclic AMP into AMP. You can see this picture. Previously, we said beta 2 agonists are going to convert and activate enzyme adenyl cyclase, and this adenyl cyclase converts ATP into cyclic AMP. And we said the cyclic AMP is very good, and it is going to activate the inactivated protein kinase to activated protein kinase. Now the point here is the next step, the cyclic AMP converts to AMP, adenosine monophosphate 5 adenosine monophosphate, by help of enzyme phosphodiesterase. But who doesn't want to convert this cyclic AMP to AMP, as we want to cause more bronchodilation in the patient of asthma. So what we do is we inhibit this enzyme so that the normal concentration of cyclic AMP which is present in the tissues should continue to work and should enhance and activate the other protein kinase enzymes and promotes the bronchodilation. Theophylline is derivatives are most commonly being used for the treatment of COPD and asthma, but the point is they comes after the class of beta 2 agonists. Beta 2 agonists are the first choice, first preferable drug being used in the asthma. Naturally occurring xanthine alkalides, which are qualitatively similar actions like caffeine, theophylline, and theobromine, they are going to act similarly as the caffeine acts. Caffeine is present in the coffee and teas as well. Mechanism of action. Theophylline and methyls, all the methylxanthines inhibit the enzyme phosphodiesterase. So they prevent the conversion of cyclic AMP into 5-AMP, 5-adenosine monophosphate. So inhibition of this enzyme phosphodiesterase leads to accumulation and increased level of cyclic AMP, and cyclic AMP causes bronchodilation, cardiac stimulation, vasodilation is being occurred. The next additional effect of theophylline is, along with like acting inhibiting the enzyme phosphodiesterase, it has an additional effect. It competitively antagonizes the adenosine receptors. Mean theophylline is antagonist of adenosine. Who is adenosine? Adenosine is going to cause bronchoconstriction in the asthmatics. This is not good. And adenosine potentiates immunological induced mediated release from the human lung muscles. This is even not good for the asthmatic patient. So Theophylline is going to give us additional effect as it antagonizes the effect of adenosine, or it antagonizes the effect of adenosine, as where the adenosine has to attach, it prevents this attachment, it attach itself, and what it do is it prevents like side effects or bronchoconstriction or mast cell action. So methylxanthines in addition inhibits adenosine action, so they causes additional bronchodilation. Methylxanthine has huge, like large number of pharmacological actions, along with the effects on the kidney or this on you can say lungs. It also affects the CNS, CVS, kidney, GIT, brain. So we are going to discuss them individually. On CNS, it acts as a stimulant and affects the higher centers. Like caffeine, 15 to 200 milligram produces a sense of well-being, alertness, beats boredom, allays the fatigue, improves the performance, and even increases the motor activity. And the patient are more active than theophylline in producing these effects. High doses causes nervousness, restlessness, panic attacks, insomnia, excitement. Still, high doses may lead towards tremor, delirium, and convulsions. Theophylline is more toxic than caffeine as it actually stimulates the medullary, vagal, respiratory, vasomotor centers. High doses may cause vomiting and gastric irritation and chemoreceptor trigger zone stimulation. On CVS, mean on cardiovascular system, it stimulates the heart and increases the force of contraction. It increases the heart rate but decreases the vagal tone, and the net effect is variable. It has a dual effect. Tachycardia increases the cardiac output, increases the cardiac workload, and even high doses may lead towards cardiac arrhythmias. Theophylline is more potent and slow and sustained dose related bronchodilation. On kidneys, like it is like coffee and tea, it is a mild diuretic. As it inhibits the tabular reabsorption of sodium or water, increases the vascular blood flow and increases the glomerulus filtration rate. On skeletal muscles, enhance the contractile power. Caffeine facilitates the neuromuscular transmission by increasing the acetylcholine release. It even enhances the secretion of acid and pepsin in the gut, and it leads towards the gastric irritation. Theophylline inhibits the release of the histamine and other mediators from the mast cells and active inflammatory cells. The next is another agent of this class, methylxanthines, that is aminophylline. Aminophylline, when intravenously being used, slowly in the acute attacks of asthma, not responding to beta-2 agonists. But a person who is not responding to beta-2 agonists, in spite of the fact beta-2 agonists are the first line of the drug, the first choice of the drug in acute asthma, will preferably use aminophylline in such a case. In acute asthma, the drugs given by inhalation route actually fail to reach the bronchioles because of the severe bronchospasm and vasoconstriction. The drug is not able to reach through inhalation route. In spite of the fact inhalation route is very effective here, the inhalation route is not going to cause absorption of the drug. So intravenous aminophylline may be tried, and 250 mg aminophylline should be injected slowly intravenously 15 to 20 minutes. The point why it is given slowly is because we know it is a very, we're going to discuss it, is a very low safety margin because it causes cardiac arrhythmias, stimulates the cardiac cells. So you want to slowly administer it in order to prevent the other side effects. Rapid IV intravenous injection may cause collapse and death due to arrhythmias. Convulsions can occur and should be carefully monitored. So ultimately, we are going to discuss the diverse effects of methylxanthines, that they have a narrow margin of safety. They stimulate the CNS, CVS, and cause GIT distress. Children are more liable to develop CNS toxicity. Rapid intravenous injections may cause sudden death. Anticholinergics. Anticholinergics are the drugs that are going to antagonize the action of cholinergics. And cholinergics are parasympathetomimetics. Fine. In the parasympathetic system, acetylcholine is the major neurotransmitter. So what is going to happen is acetylcholine in normal situation act on the muscarinic receptor present on the lungs and causes the parasympathetic activation and induce bronchoconstriction and increases the secretion of these respiratory tissues and causes the increased mucus secretion. So what we are going to do is we are going to inhibit this acetylcholine. So anticholinergics like ipratropine bromide and tritropine bromide are going to attach to this acetylcholine receptor, muscarinic receptor. They are going to prevent the bronchoconstriction caused by acetylcholine. They are going to reduce the volume of the respiratory secretion. It's very simple. I'm again going to repeat. Acetylcholine causes bronchoconstriction and increases the mucus secretion. This drug causes and so prevents the bronchoconstriction, leads towards the bronchodilation, and reduces the volume of the respiratory secretion. But they are less effective as compared to beta 2 agonists because they have a more effectiveness. Inhaled ipratropium is a drug of choice as a bronchodilator in COPD. Adverse effects are dry mouth, respiratory discomfort, and constipation, blurriness. The next class we have is corticosteroids. Corticosteroids are the main important thing about them is they are not bronchodilators. They are not going to relax the muscles who are in bronchoconstriction. They just benefit us by reducing the bronchial hyperactivity. They reduces the mucosal edema. They suppresses the inflammatory response. They are not going to cause broncho like dilation. I'm again and again saying corticosteroids are not bronchodilator. Oral prednisolone is commonly used for this purpose. Largely minimizes the adverse effect if we take the inhaled steroid, because when we take in through inhalation route, we just have a localized effect. It does not give us systemic effects. But this is not effective in acute attacks. I earlier said once the attack has happened, once the bronchoconstriction has happened, it has no value because it does not reverse the bronchoconstriction. So we can use them only for prophylactic value, and the effect of the develops after 1 week. Still, there are certain side effects when we take through inhalation route like hoarseness of voice, sore throat, or a pharyngeal candidiasis. So rinse the mouth and throat with the water after each use and can reduce the incidence of candidiasis and sore throat. We can also use them in acute asthma and chronic asthma in status asthmaticus. Status asthmaticus is a medical emergency condition of asthma in which we need aggressive therapy, medical therapy. Intravenous hydrocortisone, hemisuccinate followed by the oral prednisolone is being used. The next is mast cell stabilizer, the drug that stabilizes the mast cell. Sodium chromoglycate ketotifen is the degranulation of the mast cells by triggering stimuli. It prevents the release of histamine, leukotrienes, platelet aggregating factor, interleukins from the mast cells. Mast cell stabilizers are indicating themselves. They are the drugs that stabilizes the mast cells. Mean mast cells, when the antibodies act on the mast cells, they burst and they degenerate. These are the drugs that like hold the mast cells and protects them and stabilizes the membrane and does not allow it to degenerate and release histamine, leukotrienes, platelet aggregating factor, interleukins from the mast cell. So in this way, it is going to prevent the bronchospasm. It is going to prevent the inflammation following the exposure of allergen. So it is also used for the prophylaxis, but it's also not a bronchodilator. Corticosteroid mast cell stabilizers are not bronchodilators. So they are again ineffective in asthmatic attack. They are used as inhalers. Take 2 to 4 weeks of treatment for beneficial effect. Reverse effects are very rare, slight throat irritation, cough, and sometimes bronchospasm can occur due to the inhalation due to the fine powder of the inhaler. As being used in the prophylaxis of the bronchial asthma. Prophylaxis means for preventing use of bronchial asthma for allergic rhinitis. Allergic rhinitis is inflammation of the nose that is also due to antigen antibody interaction. Allergic conjunctivitis is inflammation of the conjunctival layer of the eye due to the antigen antibody interactions. Leukotriene antagonists. Montelukast and zolpidem have this similar action clinical utility. Leukotrienes are actually important mediators of inflammation. They cause bronchospasm, they increase the respiratory secretions and causes immediate inflammation. So these drugs are leukotriene antagonists. Mean this is leukotriene antagonist. So they prevent the action of leukotriene and they prevent bronchospasm and they reduces the mucosal secretion. Montelukast, zolpidem is going to block the leukotriene receptors and ultimately the effects are being antagonized. They are used as alternative in mild to moderate asthma. The last one is antigen antibody named as omalizumab. It is a recombinant DNA-derived monoclonal antibody selectively binds to human immunoglobulins E and reduces the allergic responses. Omalizumab may be particularly useful for the treatment of moderate to severe allergic asthma in the patient who are poorly being like controlled by with the conventional therapy. Those patients whom where the conventional therapy means beta 2 agonists, methylxanthines, corticosteroids, mast cell stabilizers are not able to improve where with use antigen antibody interaction. But because of the high cost of the drug, limitation on the dosage, and limited clinical trials, it's not currently being used in as first line therapy. So this is all about anticholinergics, all about the drugs used in the bronchial asthma. We will study in our next lecture about the drugs that are being used in cough and will lead towards the end of this chapter, that is drugs used in respiratory conditions. Inshallah, see you in the next lecture. Till then, Allah Hafiz.